Good evening, ladies and gentlemen. Welcome to, we're going down now, almost our final, but today's the second to last day of our lecture series, which we have collaborated with the Pan American Health Organization, the Ministry of Health and Wellness, the Western Regional Health Authority, and the Department of Psychology, Sociology, and Social Work at the University of the West Indies, Western Jamaica campus. We are so glad that you're here today. And it is even more special for us because today is World Mental Health Day. We have been going through the theme, mental health for all, greater access to everyone, everywhere. And we are so happy to have you joining us. We have taken out from that theme our own special theme, and we're focusing on investment. And we're saying it's never too late to start something right now. And the action time is now. We have a great lineup of panelists as well as our guest speaker today for you, and we are sure that this will be an exciting day of our lecture series. Hosting us and moderating us for this segment, we're going to be asking Dr. Andrea Garbott, a pediatrician from the University of the West Indies, University Hospital of the West Indies. Over to you, Dr. Andrea Garbott.
Hi, good evening, everyone, and we'd like to thank everyone for joining us, our participants, especially for taking the time out from their Saturday evening. As Dr. Crossman says, mental health is an investment, and we want to see that investment build into our community and into our future. And tonight, we'd like to start off our events by first bringing us greetings is Ms. Ho from the Jamaica Psychological Association. Welcome you, Ms. Ho.
Good evening. Thank you, Dr. Garbott. Distinguished members from the Ministry of Health and Wellness, the Pan American Health Organization, our Western Regional Health Authority, and of course, the Department of Sociology, Psychology, and Social Work from our University of the West Indies, Western Jamaican campus. Good evening. And to our viewers online, welcome and good evening to you as well. It is my pleasure to bring you greetings on behalf of the Jamaican Psychological Society as we join together in celebrating and recognizing World Mental Health Day 2020. Now, JAMPSych seeks to enhance the professional practice of psychology and counseling in Jamaica, and in order to serve our nation and its vast psychological needs. And one of the more recent ways that we've done this is through our partnership with the Ministry of Health and Wellness in offering virtual psychosocial support groups for our first responders or our frontline responders during this pandemic. And these virtual groups have been ongoing and continue to date. And we encourage persons, if you are in those fields, to please join one of those groups. And there's a quote that I wanted to share with us as we begin this conference and as we think about investing in mental health and how weighty that can feel sometimes. And it's a quote that many of our panelists have probably read or heard in the research already. But it is that mental health should be considered a fundamental human right and a moral imperative. This is something that we believe all persons should be able to have good functioning mental health and well-being. And so when we speak about health, we can't exclude mental health. When we speak about employment, we can't exclude mental health. Whether we're speaking about economic growth and equity in a society, we still cannot exclude mental health. And when we speak about education, of course, we cannot exclude mental health. So whether you want to build back stronger or build our Jamaica, we can't exclude mental health. And so as we continue the conversations this evening about investing in mental health, I want us to recognize the far reach of that phrase, that it is not just confined to hospital walls or a therapy room, but that it is in every sphere of our society. And so let's have the conversation, but let's also focus on this, the second part of this evening or this conference's theme, that the time for action is now. And JAMPSych, the Jamaican Psychological Society, looks forward to partnering with all of us, all of those in the mental health fraternity, in taking action as we try to invest in mental health in Jamaica. I thank you and I wish you all the best for the rest of this conference.
Thank you very much, Ms. Ho, for bringing greetings to us on behalf of the Jamaica Psychological Association. Next, bringing us greetings for this evening is Dr. Earl Wright, a well-known psychiatrist in Jamaica and also president of the Jamaica Psychiatric Association. Dr. Wright, good evening to you.
Good. Thank you very much, Dr. Garbutt. It's really a pleasure to bring greetings from the Jamaica Psychiatric Association on this World Mental Health Day 2020. I would like to especially congratulate Dr. Krausman, her team, and her supporters on organizing this excellent teleconference. The COVID-19 pandemic has created major problems for all of us, but it has also created major opportunities. It has brought to the fore that there is no good health without good mental health, and that just as we protect our physical health, we also must protect our mental health. And the theme from Dr. Crossman, investing in mental health, the time for action is now, it's never too late. This brings me to a very important mental health program that was announced by the Ministry of Health and Wellness in Montego Bay. I think it was on Thursday during this mental health week. Now, why is this program very important? It's a program involving community individuals at the grassroots levels, the barbers, the hairdressers, the church leaders, and other community leaders, asking them to volunteer and providing them with the tools to look out for one another and to help each other by looking, listening, and linking with the tools given through the mental health first aid training program. Training them so that when someone is suffering emotionally at the community level, they can pick up that something negative is going on with this individual by what they see, what they hear, and then link up with the community health aid and other systems to get the help they need. I look forward to this investment in every community health aid at the basic health district level, being trained in psychological first aid, just as they are trained to take blood pressure and test blood sugar, and also being trained in early childhood stimulation program, how to help parents to practice effective, loving parenting. Good parenting is essential to mentally healthy adult children who become productive and law-abiding adults. The Western Regional Health Authority is perhaps the best region to introduce this community-based program because of the very talented and competent, energetic leaders. The Regional Director, Mr. Green, Regional Technical Director, Dr. Camber Stennett, and our own consultant, Dr. Crossman. I'm looking forward to you really invest in this program and give it focus and energy that it deserves and motivate your hard-working health team, asking them to support this initiative and introduce and sign up volunteers for this program. The time for action is now. It is never too late to do something. Let us get the volunteers trained in psychosocial first aid. The time for action is now. I look forward to this program at the grassroots level being fundamentally helpful and changeful. I look forward to the presentation this afternoon by Dr. Cayetano, National Regional Health Advisor, and with this very distinguished panel that will be discussing about the community later. God bless, and have a very good conference.
Thank you very much, Dr. Earl Wright from the Jamaica Psychiatric Association. We all know that mental health is a human right. And as Dr. Wright said, COVID-19 has brought to us challenges, but it has also brought to us opportunities. Opportunities to reflect and to start building what we know needs to be done. There might not be another pandemic for another 100 years, but there will always be challenges as we go about. And we start from the youngest, pediatrics, my love, and we go all the way up to adulthood. So remember that 1 in every 4 person will have some mental health issue. And so we must invest if we wish to have a better community at large. Following from our greetings, we'll go directly into our program. And it is my pleasure to introduce you, Dr. Claudina Cayetano. The name was a little bit familiar and I wondered where the name came from, but then I heard something special in the background. I heard she worked in Belize, and for everybody who knows me, everybody knows that's where I'm from. So a special greetings not only from this side of the world, but also from Belize. She is the current mental health advisor to mental health at the Pan American Health Organization, and said to be married and speaks 2 different languages. I wonder what 2 languages those might be. It definitely comes with us with a wealth of experience this evening, however, to present to us on our day 5 of our mental health conference. Dr. Claudina Cayetano, welcome to you.
Thank you, Dr. Garbett. This is such a pleasant surprise, and to know that you are from Belize. Actually, you know, when I started when I was joining the Zoom, I have to say that I felt like, I don't know about you, but I felt like this was like a family reunion. You know, when you're meeting all your cousins, you're meeting some of your relatives. It's so good to see Professor Abel, Professor Gibson, Professor Dr. Earl, right? Dr. Crossman. I mean, I'm really pleased that you have chosen to invite such a distinguished panelist, and I'm so glad to be part of today's session. First of all, congratulations to you, Dr. Crossman, for doing this. As Dr. Wright was saying, I guess you are the leader in this, you know, the Western region is leading, and I'm so glad that we're doing this today on World Mental Health Day. So I'm going to share with you my screen. You let me know if you're able to, if you're seeing it.
Yes, we are.
Okay, and I probably should minimize this one here. Okay, great. So you're able to see my screen, right? I think you have said yes. So I was asked to talk about overcoming barriers to equitable care, if that is possible. So before we start this presentation, I thought I will talk about a short case scenario. Patients are what makes us have this kind of work. So I think it's important that we start with a case scenario, which is, for some of you, this is one of 1,000 patients you're probably seeing over the years. A 23-year-old young man presented to the health center complaining of general aches and pains all over his body. A physical examination revealed bruising to different parts of his body, including the face, arms, and legs. When asked what happened, the man said that the bruises were self-inflicted and that he had been forced to do them. The young man explained that over the past 3 months, his life had been very stressful. He has in his final year at the university, but was worried about whether he would pass his exams or not. He explained that one of his greatest fears is to embarrass his family. He admits to feeling overwhelmed, and 2 months ago, he started to hear people talking to him and explained that the voices kept taunting him, calling him bad names, embarrassing him, and threatening him. He said that he does not understand what is happening to him and he's scared. He explained that he has been too scared to leave his house and often spends his days in his room alone. He has not been attending classes and has been asked to leave the university. All evaluations were normal. It's a familiar case to people who are in mental health. This is nothing new, but why am I presenting this? Because if we're talking about access, if we're talking about equitable care, if we're talking about barriers, cases like this matters. And we want to know then, in my presentation, I want to take you through what is equitable care and why does it matter? What factors influence equitable care? What are these barriers? And when we talk about achieving health equity, what works? A little bit about the mental health situation, very little in the Americas, and what PAHO is doing, and what are these opportunities for the future. So overcoming barriers to equitable mental health care, is that possible? Do we have enough evidence to support this action? Do we have interventions that are culturally, that are effective? We need to work on the political will. Is there a political will for that? Do we have the necessary financing for mental health care and service delivery? Do we have sufficient resources? Are these resources reaching all the communities? As you all know, mental health has no border. Is there sufficient evidence to emphasize appropriate actions across the life course? Like what Dr. Garbert was saying, she's a pediatrician. So we need to make sure that when we talk about across the life course, there are interventions that are appropriate. So let's frame the discussion. And I think we want to frame it. First, let's talk about what is a health system. And we know that for WHO, when we're talking about health systems, we're talking about all our organizations, people, and actions whose primary intent is to promote, restore, or maintain health. And I want you also remember that, promote, restore, or maintain health. Most times what happens when it comes to mental health, we're not doing much promotion. We are not doing, it's very little promotion that we do. And this is very key, especially when it's looking at health systems. So what do we mean by health systems? Because what also tends to happen when it comes to mental health is one of the few disciplines in medicine where fragmentation is very clear. And so what do we mean about fragmentation? And what do we mean about health systems and segmentation? I think those are important concepts that we need to keep in mind when we're doing this discussion. So we know that segmentation is the coexistence of subsystems within the health system, different modalities of healthcare delivery. This kind of institutional arrangement consolidates and deepens inequity in access to health care services across different population groups. So you know, when you have a patient in the ward, in mental health, in a unit, a patient that is being treated for a mental disorder, the nurses, the doctors, no one else is going to touch that patient, only the psychiatrist. So we're starting to see what we mean about, segmentation. Fragmentation is the misalignment of incentives or lack of coordination in healthcare delivery that spans inefficient allocation of resources and impact health outcomes. And these are important concepts when we're talking about mental health. Fragmentation adversely impacts quality, the cost, outcomes, and equity. Can be overcome through integration. This is what's so relevant about integration of healthcare delivery, more specifically via integrated health services or delivery networks. This is not a new concept. We're talking about concepts that all of us are quite familiar with. So if we were to think about redefining mental health care, which I know you have thought about it, this is nothing new. I was so pleased to hear about the things that are happening, and I've been to Jamaica a couple of times, and I know thinking about redefining is nothing new. We know that. We know why we need to do that. Why we need to do that. We know that because it's a right. It's our human right. We deserve to be able to provide, to get the services. Where I think we have moved away from psychiatric institutions, we are moving away from hospitals, we're moving more into community. And what? Because we do have the tools, we know what to do, we know what works. And the who is also very important in terms of before it was only the doctor and the nurses. As I heard quite well, if I heard correctly, Dr. Wright saying, we want to be able to include community health workers, religious leaders, teachers, everyone. When we talk about mental health literacy in school for teachers, so it's no longer that you want to, it's not just the doctor and the nurse. We need to be able to think of as a team. And this is the redefining of how we're doing it. And how we do it, clearly when we're doing training, it's no longer important to do relevant. We cannot be thinking of doing training without support. No one is going, these messages will not stay. People forget. So we need to make sure that when we're doing our capacity building, there is support. People who know me knows that I do not like this word of supervision. I like the word of support. We need to be able to provide support, to provide guidance. We need to be able to be there so that people can practice what they're learning. So this is important in terms of defining, shifting this paradigm. So we're talking about from exclusion to inclusion. We want to focus on rights, on people's users, from a biomedical to a psychosocial approach. So as you know, we want to focus more on the social dimension of care, from beds in hospital to opportunities to focus on recovery, from short-term medical treatments to long-term psychosocial care, focus on rehabilitation. And this is not new either. Actually, this slide, some of you may remember when we visited Jamaica with Dr. Benedetto, he presented this. This is the shift that we want to, and I know it's happening, and I know you're doing it. So nothing new here, but it's very important to keep reminding ourselves of the relevant mental health service. What are these components of services? Because the good thing about mental health is that it's not one service that we can provide. You know, you can provide services in the community where you want to make sure that there is basic opportunities for occupation, for employment, for social inclusion, for intervention that promote understanding of mental health, intervention to reduce stigma and promote help-seeking behavior, interventions that help for early childhood and parenting program, basic school mental health program. So we're talking about promotion of self-care, integration of mental health into community-based rehabilitations. So these are all community approach that are so relevant when you talk about mental health. And of course, and additionally, we also want to make sure that when we talk about primary health care, that is provided by general primary care, case identification, basic evidence psychosocial intervention, basic referral to secondary care. And what happened at secondary care, we're talking about providing a general hospital, training, again, support, supervision. There is where we have acute inpatient care in general hospital, basic referrals to tertiary care. So the tertiary care, where it's more for a specialized care, so we want to make sure that the tertiary care has a good quality and that there is initial closure, that we want to also start to think about closure of these long-staying institutions so that we can start to develop alternatives in community settings. You know, there's enough evidence to be able to do that. And of course, we want to establish means of licensing all practitioners who are treating people with mental disorder. I mean, licensing is so important, especially when it comes to mental health. You need to be able to make sure that this is happening. Starting consultation liaison services in collaboration with other medical departments. So these are the relevant components. Now, what happens when it comes to mental health? What are these arguments for and potential barriers against investments in mental health? If you look at the perspective when it comes to public health, the arguments that is favoring greater investment in public mental health, mental disorders are a major cause of the overall disease burden. We have effective strategies that exist to reduce this burden. But what is the barriers? In potential barriers to greater investment is because mental disorders, that we all know, they're not necessarily leading to a cause of mortality in population. And we like to talk about mortality. And you know, when we talk about mortality, normally it's about suicide, but then schizophrenia, bipolar disorder, and policymakers like to talk about mortality, so this is not in our favor. Let's look at the economic growth and productivity. We know that mental disorders reduce labor productivity and economic growth. The impact of mental disorder on economic growth is not well known, and most times often unassumed, so we don't even pay attention to what that means when someone has missed work or is at work. You know, when you talk about presentism, like they're not there with the full capacity or competency to do their job. It's not being measured. Equity, access to health, is a human right. Discrimination, neglect, and abuse constitute human right violations. But persons with a wide range of health conditions currently lack access to appropriate health care, and we know that. The political influence, for example, so government policy should address market failures and health priorities. Is low expressed demand and advocacy for better services when it comes to mental health. The socio-cultural influence, we know that social support and solidarity are core characteristics of social groupings. There is the negative perception and the attitude about mental illness and this stigma. So you see these arguments that are against investing in mental health. So when we talk about equitable access and financial protection, for PAHO, we use the universal health coverage, an exercise that was carried out, and there was an exercise that was carried out by the NIH, National Institute of Mental Health, to identify a number of grand challenges in global mental health. And what they found, that improved treatment and access to care was the single most pressing concern. So when we talk about access, what is most important was the improved treatment and access to care. So and why? Because we know what is the impacts of poor mental health. The impacts of poor mental health is low educational achievement, school dropout, risky health behaviors, premature death, stigma, discrimination, human rights abuse. These are just to mention few. Reduced daily participation in society and personal high achievement, caregivers' well-being and family function is challenged. Sometimes caregivers have to leave their paying job to be able to take care of their families. Higher economic and social costs, because sometimes people, when they're suffering from a mental disorder, they leave their job, they no longer can be employed, or as I mentioned, they go to work but they're not functioning, and so they don't get to be able to be promoted in their work. So these are just few. The mental health needs, we know that the neuropsychiatric conditions are leading cause of disability in young people in all regions. Depression, as you know, is the top cause of illness and disability among youth. Globally, may not be for Jamaica case, but globally suicide ranks among 3 causes of adolescent death. And half of mental illness begin by the age of 14 and 3/4 by mid-20s. These are important information. I thought you all are so familiar with that. So when we talk about equitable care, what are we saying? We're saying that equity is the absence of avoidable or remediable differences among groups of people, whether those groups are defined socially, culturally, economically, demographically, or geographically. So health inequities therefore involve more than inequality with respect to health determinants, access to resources that are needed to improve and maintain health or health outcomes. So they also entail a failure to avoid or overcome inequalities that infringe on fairness and human rights norms. So this, I'm sure you've seen these pictures before in terms of equality. That doesn't mean justice. So we want to be able, we don't want to, for PAHO, we thought we'll leave no one behind, because equality doesn't mean justice. We need to make sure that everyone have access. Reducing health inequities is important precisely because health is a fundamental human right. So health equity means improve health and financial outcomes for individual families, regardless of their social status. Greater quality of life, greater level of functioning, lower morbidity and mortality, and improve financial stability. So when we talk about the influence of equity in health, we're talking about, when we look at universal health coverage, we want all people to have access to the health services they need when and where they need them without going through financial hardship. It includes the full range of essential health services, from health promotion to prevention treatment, rehabilitation, and palliative care. And this is actually the same thing for mental health. This is universal health for everyone, everywhere. So what influences equity in health? Access. People have the opportunity or ability to obtain the health services they need and benefit from financial risk protection. Physical accessibility, financial affordability, acceptability. So this is what is important. So universal health coverage is not possible without universal access. That's what it means. So if we look at the general barriers to access, we're talking about the physical accessibility barriers. So what are these? You know, the geographic service is too far away. When it comes to mental health, sometimes the mental health institutions are in the big cities. And when it comes to outpatient services, they offer services that are not offered at a convenient time. It's offered at the convenient time of the healthcare provider, not of the recipients, inaccessible to people with disabilities. And talk about financial accessibility and barriers. May not be the case in Jamaica when it comes to mental health because they have is free of cost. But in some other countries, there is a high cost to that. But look at the acceptability barriers when it comes to patients perceiving that maybe the services are not effective. So we have the social and cultural factors, the language, the age, ethnicity, religion, and these sometimes, discourage people from seeking services, and not to mention the stigma and discrimination. So what are the barriers that we need to overcome? So we talk about mental health resources, in terms of some, as I mentioned, centralized resources in psychiatric hospitals, and most time there's a resistance by mental health professionals to move to communities, and vice versa. So this resistance can also be detrimental, and it's very important to be able to overcome. The need for transitional funding, the shift to the community-based services. Difficulty when we talk about integration of mental health into primary care, the difficulty with that is that there is the tool. So there is, for example, for us, the image gap, and we have done training. But what is the problem is that if the training is not accompanied by appropriate support and supervision, this is not going to stay. People are not going to practice what they're learning. If we want them to practice what they're learning, they need to know that there is support, there is appropriate guidance so that they can continue doing the practice. So, and then sometimes too, that we also know that primary care workers, they're already feeling that they are overburdened, so they don't want to do anything else. Political will, inconsistent and unclear advocacy, we need, by mental health advocates. We know that we don't all speak the same language. And that's the difference when it comes to mental health. We need to learn to speak the same language, especially if we want to tap into our political leaders, because political will definitely make a difference. And we need to bring in people with lived experiences, people with a diagnosis, and most times they're not, these persons, most times they're not organized, and so they are not powerful in lobby, in presenting themselves. I want to stop a little bit just because while I'm reading this and talking about people with lived experiences, I remember the first time when I met Dr. Wright, where they were having this group of patients, and I think that was the time when he was director of mental health program, and having people live the experiences among them, when they were planning policies and talking about services. And that for me, that was so relevant to see how empowering users or people with lived experience, it makes such a difference. So this is nothing new for people in Jamaica, because this has been happening for many years. Leadership to develop and offer sustainable services by government and their partners. So this is so important, leadership, as I say, people with lived experience. Achieving health equity, what works? Well, we know that from PAHO, we're saying if we're to see health for all by 2030, we want primary health care that we think is the most efficient and cost-effective way to achieve universal health coverage around the world. So we think about, this integrated quality people and community services. Same, achieving health equity then, what will work is that it's very important, especially when we talk about mental health, we need to address the social determinants of health, because that's the only way for us to improve access to health services. We need to empower groups in question through systemic changes, law reforms, changes in economic or social relationship, good governance, sound systems of procurement and supply of medications and health technologies, and well-functioning health system informations and other critical elements. We need that because we need, when we talk about monitoring and we're talking about health information system, you need to have a functioning so that you know what is working, what's not working, and whether you're making an impact or not. So the broader social determinants of health are so important, specifically when it comes to mental health, because, and we know that these social determinants of health are these conditions in which people are born, grow, live, work, and age. So income is important. We have to think of, employment, the working conditions, education, social exclusion, gender, ethnicity, disability, early childhood development, neighborhood, and housing. Very important to keep that when we're talking about mental health. So what we have evidence to, from evidence to action to transform mental health delivery, there is sufficient evidence. We know that works. We have the tools and resources for implementation. As I mentioned before, that when you use the image gap, there is training for primary healthcare providers who are not specialized in mental health, training for community members in basic psychosocial skill, psychological first aid. I'm glad to know that this is something that you're starting, and building capacity for health system, because we want to be able, as I mentioned, to strengthen the health information system, improving our surveillance, especially like now with COVID, the data collection reporting, it's so relevant to do. Development and implementation of mental health plan, policy, and legislation. We need to have a map so we know what services need to be provided. So burden of mental health, inequity is high versus in low-income countries. So there's a high treatment gap. There's concentration of human mental health human resources in urban areas, in the capital city. There's limited access for vulnerable groups. And these are important to consider when we're planning for mental health. So now we all know about what COVID is bringing. I think if anything, if nothing else went with COVID, is that mental health inequity is much, much more than it's more prominent than ever. It's amplified, especially among previously and among everyone. All of us are at risk. I don't think, some more than others. And we all know that, people with pre-existing condition, with disabilities, we all know these facts. We don't need to stay here because we already know this. So for us, with PAHO and health equity, this is so important because to lead the strategic collaborative effort among member states and other partners, we need to promote equity in health. We support our member state in this effort to achieve equity in health through work on gender equity, ethnicity, and health. We want to ensure and promote the right to health, striving to improve the social and environmental determinants of health. We want to measuring, analyzing, and monitoring health inequalities, strengthen health systems and promoting system reorganization to improve efficiency and access, and knowledge management. It's all of so important areas that we want to focus on. I want to look at what happens when it comes to mental health, because as you know, focusing on hospital is not, it is not giving the return on investments. Only in psychiatry, we see these things happening. For example, if you look at mental hospitals, the length of stay. So here I have, at the top, you see the median of all countries, the Central American and Mexico, South America, non-Latin Caribbean. And I actually look at the WHO aims for Jamaica. Jamaica has done WHO aims. WHO aims is the WHO assessment instruments for mental health. So one was done in 2009, and there was another one that was done in 2015. Patients staying less than 1 year in a hospitals, and if you see the percentage, 29%, it ranges between 29, in South America 51, in less than 1 year, and in Jamaica, this is also for percentage, 14%. But what is relevant about this length of stay, why I think it's important that we pay attention to, is that patients staying, The last column, the last row, patients staying more than 5 years. So in most countries, as you see, 66%, 71%, and again, too, in Jamaica, 74%. It's similar like in the other countries, but it's only in mental health you see people staying more than 5 years and even sometimes 10 years or the lifetime in a hospital. This is not promoting good mental health. And for patients staying between 1 to 5 years, the majority of them are male, 62%. So few recommendations that we need to think of is that we need to think of, when we talk about protect mental health with actions on social determinants, so educating everyone, that will help to enhance equity and alleviate poverty, engage civil society in a meaningful way, use public policy to protect mental health, involve the young people with lived experience, or just in general, people with lived experience. We need to invest, and that's the theme for this year, invest far more in mental health. Focus on intersectoral collaboration with education, collaboration with the Ministry of Labor, Ministry of Human Resources. Make more and better investment in mental health, strengthening monitoring and accountability. We recently, PAHO collaborated with the Ministry of Education in the mental health literacy in schools. And the hope is that this will also be able to improve the literacy of teachers in schools. As we said before, teachers, with COVID, there's changes because of the virtual training, but kids tend to spend between 25 to 30 hours in schools, and teachers should have the competency to be able to see signs of problems that the children are having. So it is important to equip teachers, build their literacy in mental health. We do not want teachers to be doing the diagnosis. That's why the psychiatrists or psychologists can do the diagnosis. But we do want teachers to have the skills to be able to know when there is something that needs to be reported. As mentioned before, half of mental health disorder can be diagnosed during, in 14 years of age. So that's the relevance of the school mental health literacy. So what are other opportunities for the future in Jamaica? As some of you probably know, that we have done this the case for investment in mental health, to look at the return on investment, to be able to scale up treatment for depression, anxiety, and psychosis, which were among the 80% of diagnoses that we're seeing. Anxiety, psychosis, and depression. So the idea here is to provide treatment and care to people that, if you do capacity of primary healthcare providers, if you train them, we support them, that the return on investment is much better. So here we also want to make sure that there's a coordinated psychosocial rehabilitation intervention, support users and their family, talking about referral and back referral, these mechanisms that are so relevant, and the coordination of inpatient activities by teams in general hospitals. So what are we doing from some of the initiatives that we're doing? We have launched a couple courses on suicide prevention. One of our publications is the Atlas, which is done every 2 years. There is a burden of mental disorders in the region. There's some publications on management of epilepsy. I did not include one on dementia, which we know that's also a key issue in our regions. And then there's now with COVID is much more ever before in the importance of building back better when we talk about mental health and psychosocial support. And I also, I'm so glad to hear that there is a conversation to use the psychological first aid in disaster management. We have recently launched the psychological first aid online. This is an online course. It's a virtual course. It's through the campus, through the PAHO campus, and it's a 12-hour self-paced training, and it aims to equip lay persons with the tools to appropriately provide the initial response to individuals that are experiencing psychological distress secondary to crisis. So the PFA, or psychological first aid principle, is the look, listen, and link. So to learn to know when to refer, when to, and how to provide support that is humane. So this is an interesting initiative, and I encourage you to actually, go to the campus and have people register. So some of these publications, like the Mental Health Atlas, some of the data that we use, and this is happening every two years. We also are working on or updating the Mental Health Plan of Action, which ended in this year, 2020, and now we are doing an appendix to include more indicators and increase the duration from 2020 now to 2030, so that it also ends at the same time as the SDGs. So this is ongoing. Some of you perhaps have participated in the consultation that has been happening, because we have had different consultations to get people to provide feedback in terms of what would they like to see for the mental health plan of actions. And the Atlas, as I mentioned before, is an ongoing, is done every 2 years, because we want to be able to do an assessment of what's happening when it comes to policy, plans, and legislation, looking at multi-sectoral collaboration, looking at financing, integration of mental health, availability of services, social support, the issue of promotion and prevention, and of course, mental health system. So it's done every 2 years, and these are indicators that helps to see how the countries are doing. Remember I mentioned my case scenario. So this case scenario, what is relevant about a case scenario like that? Because if we're thinking of reducing barriers, we're looking at a case scenario of a case for our first episode of psychosis. What we know about, there's studies that we know that if it's treated appropriately, it leads to good recovery. We're talking of a young man who can have access to support to individual or group psychotherapy. There could be family support and education. There's access to medication. There's support for employment and for education, so he can return to work or school and achieve his personal goals. Case management, all of this will help to do problem solving, so that first episode of psychosis have a higher rate of treatment. We don't have to think of someone who has to be on the street begging and exposing themselves to danger or endangering or others. So there is hope. So overcoming barriers to equitable mental health care it is possible. We have evidence that there is enough evidence. We have interventions that we know are interventions that can work in terms of focusing on persons with mental health problems and their family and the settings, but this is not enough. Just having evidence, just having interventions is not enough. What we need more, we need, in addition to the evidence that support the actions, in addition to the interventions that are effective, and we need to make sure that they are also in the context of the culture, the political will is needed to take actions that are sustainable. Financing is very important for mental health care and service delivery. Allocation of sufficient resources, human housing, and medications, that's also very important. And sometimes this is left to the Ministry of Health, and we know that it's not the Ministry of Health who has to provide housing. It's not the Ministry of Health who has to provide job. So this is why the importance of intersectoral collaboration. Reach the communities, because mental health has no border. Provide, as I mentioned before, actions that are across the life course. So with that, I want to end my presentation. Thank you very much for listening. We had some references that I have used to be able to do this presentation. Thanks for the opportunity to participate in this session.
Thank you very much, Dr. Claudina Cayetano, for that interesting presentation. Quite comprehensive. You started off from the very beginning and worked your way from problems all the way to possible solutions that we can move on with. There's one question that has come up from the audience already. This one has to do with the slide where you had put up with patients who were in institutions and the duration of time that they spent in institutions. One person asked, are those cases of long hospital stay actually cases of mental illnesses, or are there social cases that we would house on wards, for example, because maybe family hasn't picked them up or they don't have any family? Is there any way to differentiate those cases?
There is a way to differentiate those cases because, as you know, as we all know, if you have a person who suffers from psychosis and acute psychosis, and Jamaica was one of the first countries that done research to show that a person with an acute psychosis can be treated between an average of 22 days or, less than. So you don't need to stay in a hospital for over a year. So once you stay in 5 years, 10 years, the person clearly is there for housing purposes. That does not mean that from time to time they may have a relapse. They can have a relapse. It's like any other medical illness. People can have relapses. So it is possible that through the time they can have relapses, but the majority of the time, this is only for housing purposes. And this is why I was saying that this is not Ministry of Health responsibilities. This housing belongs somewhere else. But unfortunately, the length of time that patients had been in the hospital, they tend to stay and they are nowhere to go. So families are not involved. They have lost opportunity for to be productive, to be able to have to be functional, to have a job, to look after themselves. So they stay in the hospitals for a long period of time. And we're talking about, I think I show between 70-90%. So it's a very, it's a high number of people that stay. And it's not only on Jamaica, as I was saying, it's also happening in many countries that have psychiatric hospitals. This is why the move is important for the institutionalization, because most of these institutions only serves as home, and they're not providing the right care. Most times there is a lot of human rights violation. I hope I answered the question, but I know that the colleagues from Jamaica to know this thing very well, that this is not about, this is not a biological approach. This is not about biomedical approach. It's about more social support than anything else.
I think you answered the question quite rightly. Recently, within the news, many of us in Jamaica would have taken note of inmates with psychiatric illness who were incarcerated and were left there for quite a while. And as we progress as a country, these things, there are changes that are being made. So we're happy to learn that we're learning from some of our mistakes that we've made. Another question that has been posed is, what strategies have been used successfully in the past to enlist government to invest more in mental health?
And that, Dr. Garbett, I should have mentioned that too, like this institution absorbed so much. I don't know how come I removed that slide, because the little bit of money, the little bit of funding that, so you have in most countries, the funding that health receives compared to that, and then there is a percentage that goes to mental health. In Jamaica, probably 5%, in some countries, 2%. The little bit of money that will go to mental health, 60 to 70% of the money of the funds go to the psychiatric institutions that are keeping people there for years. And the community where the work is happening, or hospitals that have general hospitals that have units, they don't get the amount of services or the amount of funding that they require. So this is what tends to happen. So the strategy has to be that we need to be able to reduce the admissions to these institutions, we need to be able to close the entry door, and we need to be able to open the exit door to give more opportunity for people to be treated in their community. And we need to be able to find more funding for more management of patients in their community. So remember I mentioned about, case management, working in team, doing the capacity building at primary care, but not just capacity building. It's also, they need incentives, they need support. So there is very clear strategy that what needs to happen in order to be able to shift the services from an institution to a more community base. And that also helps in terms of reducing the stigma, because again, a lot of the time what tends to happen is that there's a high stigma and discrimination. So there is so many things that these are different strategies that can happen in order for us to be able to shift these services from institution to community. The issue of promotion, the issue of mental health literacy, having this kind of conversation that we're having now, it's very important in order to bring awareness on the importance of mental health.
Thank you for that response. There's one part that really struck me, and you just mentioned it, mental health literacy. I work in a world of disabilities, from developmental delays to autism, ADHD, and I will say there is stigma even around those diagnoses for a child. But one thing I've learned along my way and through my daughter is that when you're exposed very early, you don't see a difference. So she just thought that she was in school with somebody, and this little boy would go for therapy, and he was the one who stole her chips every day in a playground, and she saw nothing wrong with it. He was, maybe a little different, but nothing wrong with him. He was just another kid in the class. So when I go back now, and I want to ask you a little bit about feedback from this one, is the mental health literacy. Sounds interesting. It talks not only about investment, but it talks about putting in work to create destigmatization and hopefully acceptance. Have you had any feedback from work that has started within that, whether it's from within Jamaica or outside?
Yes, for sure. I think it's important that when we talk about literacy, and I know that the colleagues from Jamaica also have done some work and talking about literacy, when it's for everyone. I don't think it's only for in education. And I'm glad that you mentioned that, because your daughter is exposed and so it becomes easier. And that's another thing we don't do. We teach our kids how to comb their hair, how to brush their teeth, but we don't teach about emotions, about how to protect your mental health. And that's that should start from young. So literacy is good for teachers, but it's also good for media, the journalists. I think it's so important, because the way how they portray or they talk about mental health in the media, that also impacts the way how people are discussing mental illness. So no one wants to go and seek help. People prefer to suffer in silence because they're scared they'll be stigmatized. So literacy has to happen, from everyone. Media, at work, we spend, some people spend 40 hours a week at work. So you need to have a mentally healthy workplace that is also welcoming, that is okay for you to say that you have been diagnosed with a depression or, with an anxiety. Is very few people will want to hire people who have a mental health problems, precisely because they don't think that they are capable of doing a good job. But it's okay if they have the hypertension or diabetes. So this kind of discussion is so important in terms of what the value of having literacy, mental health literacy in different for everyone, because I think that's the discussion that we want to be able to see happening. In terms of each country have their needs. You were asking what, I guess, the return on invest, whether we're seeing, like, for example, in Jamaica, we did this study for return on investment, looking at depression and anxiety and psychosis. If you invest in that, what it means. That's one part. for Trinidad, as you probably know, like in terms of literacy, we did some training, but not necessarily literacy, but it was on suicide, on reporting on suicide, responsible reporting on suicide. As you may know, Jamaica, Guyana, and no, sorry, not Jamaica, Trinidad, Guyana, Trinidad, and Suriname in the Caribbean have the highest rate of suicide. And we did some training in Trinidad for the journalists in terms of responsible reporting. And that had helped to be able to, and there was a monitoring and evaluation framework that was put in place. And that helped to decrease a bit the reporting on suicide. I'm not so sure if that helps to answer, like, you know, if you do some training and if you support some initiative that can help to change the discussion and the way how people are reporting and talking on mental health.
Okay, then. Thank you very much, Dr. Cayetano. It was a pleasure listening to you. As I said, not only outlining the barriers that we experience, but surely looking at ways that we can pave the way forward in trying to overcome these barriers. Thank you very much for your presentation.
Thank you for the opportunity to be with you.
At this time, I'd like to introduce to you our medical representative from Janssen, Ms. Marsha Clark.
Hello, good evening, everyone. It's a pleasure to be here on this platform with so many distinguished guests. Let me try to just bring up my screen. Okay. All right, so thank you again, Dr. Crosman and team, an excellent conference so far. So Janssen, you know, we have always been a partner for over 60 years. Janssen Pharmaceuticals, we've been behind innovative research and development, which has helped to revolutionize how mental illness is viewed and treated, right? So we started with our first molecule that was approved in the 1970s, haloperidol, which is well known. Then we launched our long-acting injectable, haloperidol decanoate. 10 years later, we came up with our first our second generation antipsychotic, risperidone, and later our long-acting injectable, risperidone. And we are still moving along in terms of our development. We launched our paliperidone palmitate, which is, we have our oral presentation, or ER, but just to give you a better look in terms of our LAI portfolio, we have in our public system available now Invega Sustenna, which is a once monthly injection available for schizophrenia patients. And we recently launched same paliperidone that is available in Invega Sustenna as Invega Trinza, which is our once every 3 months long-acting injectable, which has come to revolutionize the management of schizophrenia. So is schizophrenia a public health issue? Yes, it is. Because it affects these patients when they're entering their stage for maximum development and productivity. And it's listed amongst the first 10 leading causes of disability in the age group 15 to 44 years. So with schizophrenia, recovery is possible. And I've seen that in my many interactions, in my many involvement in the clinics, and that has encouraged and inspired me to keep interacting and helping patients to overcome this challenge of relapse. So preventing relapse is critical in our road to recovery, and it is possible. Just to remind you that with the natural course of schizophrenia, each relapse is linked to brain tissue loss and functional decline. And we can see that with our slide that shows progressive disease. We can show this, see it with our disease progression slide right there. So time is brain. So there is an article I will share with you after. So your greatest opportunity to modify the course of schizophrenia is actually in the early phases of the disease. So LA long-acting injectables such as Invega Sustenna, which is available in our public system, should therefore be considered a little earlier in our disease. So a shift towards that may help to prevent the further decline that we see in our patients. This is a very interesting article where for first episode psychosis, psychiatrists should actually behave like cardiologists, starting long-acting injectable antipsychotics soon after a psychotic episode can prevent a more destructive second episode. So we can change disease progression. You as psychiatrists can change disease progression and should intervene as cardiologists in the prevention of relapses. So the goal of a cardiologist when treating a patient who is suffering from the first heart attack is to never let the patient suffer a second heart attack. Similarly, in first episode psychosis, it destroys brain tissue and compromises brain connectivity and plasticity. Sorry, let me go back. Right. So the first infarction damages parts of the myocardium, and similarly, we want to prevent destruction of brain tissue. And as I mentioned earlier, time is brain. Let us intervene earlier. The paradigm has shifted to introducing our long-acting injectables a little earlier in our management of patients with schizophrenia. So from Janssen Pharmaceuticals, we have Invega Sustenna, and I mentioned earlier that we launched our Invega Trinza. Our Invega Sustenna is available in our public health system, and hopefully our Trinza will be included soon. And I'll go to the theme, investing in mental health, the time is now. So Invega Trinza, with Invega Trinza, what it allows, just to give you a background on it a little bit, what it allows is actually, so a 3-monthly injection. It allows less visits to the clinic. It allows time for staff to probably intervene a little bit more and engage the patient as it results to psychosocial issues, substance abuse management. All of this is possible. So patients Invega Trinza would be for a patient who is actually stable on Invega Sustenna, and then they're switched over to Invega Trinza. So especially now in our pandemic, where we have problems with access, some persons aren't able to get to their clinic visits, having a drug such as Invega Trinza involved in our formulary would be beneficial for the appropriate patient. The appropriate patient meaning some patients who may need to go back to, who are gainfully employed, but they would like to go to school. They would like to do graduate studies, and we need to think about these things. What are our goals what are our patients' goals? Are we helping them to achieve those? So basically this just shows you in terms of our transition, which I mentioned before, but we can get into that later on, just to emphasize that the patient needs to be on Invega Sustenna for at least 4 doses before they get to Invega Trinza. So as a company, we are here to support in any way where we can. Actually, there are discussions happening now with our Ministry of Health, where we are trying to offer Invega Trinza at a special with special conditions for our public systems, because we have received a lot of feedback from our consultant psychiatrists or mental health officers about including Invega Trinza for some of these patients. And with the additional of Invega Trinza, there will be no additional burden on the budget, as we have made the price comparable to Sustenna. So within Invega Trinza, it's a different kind of conversation, right? We're taking the patients to another level. Oops, sorry, let me go back. Right, so just to close, I know Dr. Krosman gave me 5 minutes. I think I'm probably there. We are here as a company, I mentioned earlier, to support in any way we can. We have Invega Sustenna available in our public system. We have seen, especially now, where in our pandemic, it has served our patients so well. And when our Invega Trinza is included later, it will do so much and even more. Because with our Invega Trinza, our relapse rates are much more reduced than even with Invega Sustenna, which is what we're trying to prevent, or relapses. So thank you again, team, for having me. You're not in this alone. We're all in this together, and you can always count on Janssen to be a part of. You can call on us. We're here. Thank you so much again for allowing me to share this time.
Thank you very much, Ms. Clark from Janssen on Invega. There's a quick question there to you. So I guess there are people who need for you to come back out to detail them. They're asking about contraindications for Invega Trinza.
Okay. So just to reemphasize that the paliperidone that is in Invega Sustenna is the same paliperidone that is in Invega Trinza, right? In terms of contraindications, we found that with the second generation antipsychotics, we have less of the side effect profile that you would have with typical. However, patients could get weight gain or a little of that, but we've seen it less with paliperidone molecule. Sometimes there may be increase in prolactin levels in terms of adverse effects, but that can be monitored. And if the patient needs to come off, then they would have to come off. But the most important point here is it's the same paliperidone that you've been using in your clinics, which is why we emphasize that the patient is stable on Invega Sustenna before conversion to Trinza. So you're basically using the same molecule, just that this molecule is designed to release a little slower in the system. And the difference is that they will come to the clinic every 4 times for the year versus every month.
Okay, then thank you very much. We'd like to thank all our presenters so far. Our Dr. Earl Wright, who greeted us earlier, Ms. Ho from the Jamaica Psychological Association, and Dr. Claudina Cayetano. We now move forward into our panel discussion. Blueprint for building a mentally healthy community. Our panelists will be Professor Wendel Abel from the Department of Community Health and Psychiatry. He's the head of the department at the University of the West Indies. Professor Roger Gibson, head section of psychiatry, University of the West Indies, Mona as well. Professor Maureen Sams Vaughan, who's a consultant developmental pediatrician and also past head of the department. And Mr. Michael Tucker, our Executive Director of the National Council on Drug Abuse. So we'll start off with Professor Wendel Abel on a blueprint for building a mentally healthy community. Professor Abel.
Thank you very much. Let me quickly just thank the organizers from Western Jamaica for once again hosting another conference, World Mental Health Day. It's often said that the West carries the rest, and I'm proud to identify with the West, having worked there for many years. But in looking at this topic in terms of promotion of building resilience in the community, I found it a very difficult topic because in the sense that I didn't know what angle I should probably have approached the topic from. And I decided that, as usual, I'm going to just approach things from the perspective that I think is most relevant. And I want to do it from within the context of what is happening to us in terms of COVID. Because I think right now we're having a real mental health crisis. And why it's so important? Because, COVID it's an unprecedented crisis. It's global and it's devastating. It's a period that is marked by great uncertainty. And what is interesting is that there is no rule book. We all have to start from scratch. On a very fundamental level, COVID presents an existential threat, yes? And when we look at the existential issues, it generates a lot of fear and anxiety about death and dying. Just this morning, I heard a colleague died, and and one would like to extend condolences to the family and to the wider medical community. But for about 45 minutes, I got very sad, depressed. I became anxious and fearful. And I'm disclosing, it's the truth, because I'm a medical doctor. And so every now and then, this existential threat becomes real to me, right? And I would imagine to everybody. But COVID also has destroyed our social connections because of the social distancing. It has led us to question our purpose and meaning in life. And I think it also has forced us to highlight the importance of personal actions. Earlier I said that COVID, it's global. It affects every country, people across the life cycle, young children, youth, adults, the elderly, and some are more vulnerable than others. It affects people in all settings, home, school, work, church. It has changed the way people worship, our community at the level of policy making. And we're now beginning to see the resultant effect in terms of the emotional response, which is widespread, the fear, the anxiety, the uncertainty, the depression. And, recently, Professor Elimaya Shero reported increased depression among elderly. We just completed an online survey in Jamaica, and it also highlighted the high levels of depressive symptoms and anxiety among the population. It's creating adjustment disorders. It's impacting on children and the adjustment they have to be making in terms of remote learning. And the question then, having said all of that, how do we build resilience within the community at a crisis? Because we're at a critical juncture in our existence as human beings. And I think in terms of building the resilience, right, within the community, and I'm just going to guide us in terms of some of the things that I think that need to be emphasized, is that we certainly have to emphasize the importance of personal actions, that they matter. But in doing that, we have to make sure that the messages are clear, especially the public health messages. They are clear, they are simple, and they are doable. So I know nowadays we're beating up on people within the society in terms of wearing masks. And the question is, can everybody afford a mask, and people not adhering to curfew? And is that possible in many communities where many people live in a house and the house is really only for sleeping, where people probably sleep on beds and floor? So we have to make sure our messages are clear and doable. We have to guide people in reframing the perspective and just help them to work through, to focus on the positive. I don't think, for example, it helps having these regular conferences where we're counting bodies and counting cases. It's important to keep informed, but I think in doing so, we have to make a decided effort, a concerted effort to help people to reframe things in a positive way. We have to help them to normalize their feelings. And I spoke to that, the anxiety, the uncertainty, the fear, that they're normal and natural. We have to help people to live in the present, right? And I think that's a very important thing as we guide people along. And most importantly, we also have to help them to recognize the value of social networks, especially at this time, and help them to strengthen and to consolidate their social network, especially vulnerable people like the elderly, persons with disability, persons with mental disorders. And so the Ministry of Health must be commended in the launching of the community-based program in psychological first aid. Some of the good points about it, they utilize all members of the health team. I like how the extent to which they're using the community health aides, who are critical gatekeepers in our health system. And over the past 2 years, we've been doing quite a bit of that at the University of the West Indies, where we have been training our community health aides to give basic mental health intervention. And its early findings have indicated that that is very effective, low cost and very effective. We also have to, it's also in the Ministry of Health program, we know that they're also utilizing community resources and volunteers, the barbers, the hairdressers, faith-based organization. And so I think as we move forward, COVID is going to teach us a lot of lessons. It's forcing us to mobilize our resources to certainly build the resilience and to respond to what is a global pandemic at this point in time.
Thank you very much, Professor Abel, for your presentation in terms of remembering that we need to normalize our feelings, we need to live in the present, and the value of social networking. So whilst we remain physically distant, we still remain socially connected. We now move on to our other panelists. This is Professor Roger Gibson, as he gives us his views on the blueprint for building a mentally healthy community. Professor Gibson.
Thanks, Dr. Garbett, and good evening, everyone. Thanks also to Dr. Crossman and her team for organizing this conference and as well for inviting me to be a part of this panel. I'm going to go ahead and share screen. And in so doing, oops, there we go. In so doing, share a few of my thoughts about a blueprint for building the mentally healthy community. So to put things in context, what does it mean to be mentally healthy? It means a number of things. It means having a sense of well-being. It means being actualized or being able to live up to your full potential. It means being able to have adaptive responses to stress. In other words, to cope with difficult situations like the COVID pandemic that we are all facing. It means being able to be a productive member of society. And it means being able to have a genuine sense of fulfillment as well. If we apply those concepts to communities, then we're considering not only individuals, but groups of people and the relationships among them. Now, according to the WHO, the blueprint for a mentally healthy community should look something like this pyramid. So notice that at the bottom, we have a broad base with non-medically oriented or informal resources and services. And this is where there is greatest need and the least associated cost. At the peak of the pyramid, we have the least need and the highest costs. These resources and services include things like hospitalization and other specialized approaches. Now, all parts of the pyramid are important and interconnected. However, the elements at the base are often underappreciated, although their positive impact has the potential to be quite to be quite far-reaching. I believe that it would be worthwhile to renew the focus at the base of the pyramid. It contains resources and services that affect all aspects of life. It depends on strong intersectoral linkages with the involvement of various entities, like those shown on the slide: schools, workplaces, churches, NGOs, etc. Some of the non-traditional resources and services would include things like housing and other social support services, especially for the very vulnerable. Parenting skills development, early childhood support, mental health literacy in schools and elsewhere, employment assistance programs, mental health screening, self-help resources, mentorship opportunities, peer support, and basic counseling. For this approach, there is a need for strong foundations, which would include vision, leadership, expertise, and some infrastructure. Also essential are community engagement and participation. In an atmosphere of inclusivity, community members need to appreciate the meaning and value of mental health, as well as the pathways that will lead them to a mentally healthy life. I see all of this as kind of a cycle, with establishment or enhancement of resources, leading to greater appreciation of mental health issues, which leads to an increased demand of services and resources, and the cycle continues until the demand is fully met. Now, I think that a way to jumpstart this process would be at the point of increasing resources and services. For example, with a mental health promotion program, or with a highly visible project that also has highly visible results. Through the course of the proceedings so far, we have been talking a bit about COVID-19 and the impact that it has had and the mental health implications. One of the earlier speakers also mentioned that the COVID-19 pandemic was an opportunity. And I see it in the same way. I think that what the COVID-19 pandemic has done is that it has personalized mental health issues for a lot of us. So many persons who would ordinarily not think about mental health are experiencing mental health issues themselves. There's a greater awareness about mental health. And I think that this would be a good opportunity for us to capitalize on that as mental health professionals and as public health professionals, and to pivot that increased awareness into more of a medium-term and long-term strategy. In other words, let's take advantage of the fact that persons are now having conversations that they were not having before about mental health, and see if we can drive some of this investment that needs to take place. Those are my thoughts for the moment, and I hope to discuss further on the issue in the discussion that follows. Thank you.
Thank you, Professor Gibson. I'm sure we're going to get back to you for that discussion. It's now my pleasure to introduce to you Professor Maureen Sams Vaughan, our developmental and behavioral pediatrician.
Thank you, Andrea. I'm just going to try to share my screen just in case you have the presentation, just in case it all doesn't go well. There we go. All right, everybody seeing it?
We're seeing it now.
All righty. So I decided to look at child mental health. And for child mental health, I kind of went right back to the basics, because sometimes when we talk about child mental health and we're talking in the community, person say, really, children have mental health problems? They didn't think so. Their children just have bad behaviors. They don't necessarily have mental health problems. So I'm taking us a little back in terms of this. So what is child mental health? It's often considered different from adult mental health because of the developmental perspective. You know, when you work with children, you have to think of the difference between a 3-year-old and an 8-year-old and a 16-year-old. In child mental health, we have two different aspects, completely different. And we're going to look at how different they are. And because of how different they are, then at the end, we're going to look at all that we need to do. So we have the developmental disabilities, which is the first group. And pediatricians call it developmental disabilities. And this doesn't help our case at all because we call it by many different names. So in the DSM-5, it's called neurodevelopmental disorders. And then the second group of mental health disorder that children have is the child mental health disorders that more approximate the adult mental health disorders. So let's talk a little bit about this one. It's a group of conditions with onset in the developmental period, and it manifests before primary level schooling. And it must impair you in some way in your personal, your social, your academic, or your occupational functioning. The main point I want to bring across here is how common they are. We don't have data for Jamaica. The closest country to us that we have data for is the United States. 1 in 6 children has a developmental disability. And these are the common things that we see: attention deficit disorder, learning disabilities, other developmental delays, stuttering, autism, intellectual disability. And when we want to know how to build resilience, we often look at what's causing our problems. And when we look at the factors that lead to developmental disabilities, we see that there are a lot of health factors, parental illness, genetics, parental behavior, perinatal complications. But if you look at what is highlighted there, you see that most of them, we don't know what's causing them. And then for the others, you know, it's actually behavior or illness. So if we want to build a community of health around these kinds of conditions, the main areas that we would have to address is making sure that we have healthy babies through healthy families, and that we have healthy children who have access to healthcare. So that's one of the things that we need to do. But because so many of these cases are unknown, we also need to build a system that identifies children early and provides them with the services that they need early. When we look at child mental health problems, on the other hand, and look at this, child mental health problems occur with the same level of frequency as developmental disabilities. 1 in every 6 children in the US have the 3 most common disorders. And what are those? Depression in 3%, anxiety in 7%, and behavior or conduct problems in another 7%. When we look at these risk factors, though, we see that they are completely different from the others. So if we want to address now the child mental health problems, we have to look at other issues: harsh discipline, parental distress, parental depression, children's physical health, over-involved or protective parenting, and peer bullying. There are genetic factors as well to child mental health disorders, but the environmental factors really outweigh the genetic ones. So primary prevention in this section of child mental health is mainly about parenting support and providing public education on these child issues. And in fact, so many persons have mentioned parent support before. And I wanted us to look at how well we are doing at trying to help children's mental health. We're not doing so great as physicians, as a health sector. Clinical judgment identifies less than 30% of developmental problems and less than 50% of behavioral problems. So how are we going to move along to ensure that we have a mentally healthy child community? We have to do a number of things. We have to provide parenting support at all levels, in parenting support at all age groups in the community. And this means, when we think of parenting support, persons almost always think about the very young child. And we often don't think about the adolescent and the support that parents of adolescents need. And then at the level of primary care services, we need to ensure that our health services can screen for both the developmental and mental health disorders. This means that we have to shift our training in terms of ensuring that persons understand how to screen at the health sector level and that they can provide developmental and psychological first aid. This has been mentioned a lot. It's important to be able to provide this first aid because our research shows us very clearly that many persons do not actually go on to seek secondary services, even when we refer them on. But we not only need to strengthen our health sector, we also need to strengthen our education sector because that's where a lot of our children spend their time and their days. So teachers also need to be trained in psychological first aid. And if we address mental health literacy in schools, then we will have peers helping peers. And we know that, especially in the older children, in the adolescents, that will be particularly helpful. But we must always have the services that can support once we identify our children who need help. So provision of specialist services is going to be very important at the secondary and tertiary level. Thank you.
Thank you very much, Professor Sams, for your presentation on a blueprint for building a mentally healthy community. It was directed to our children. Our last panelist will be Mr. Michael Tucker, who is the Executive Director of the National Council on Drug Abuse, with his views on building that mentally healthy community.
Okay, thank you very much. Thank you, Dr. Krosman and team, for giving me the opportunity to participate in this very important discussion. And I hope at the end of the day, we really benefit from the other presentations and my presentation, just looking at mental health and a way forward. So we just want to look at NCD's perspective regarding blueprint for a mentally healthy community. I've emphasized the link between substance use and mental health in previous sessions, so I trust you acknowledge preventing and reducing substance misuse, critical component deserving of focus and overall investment to build a mentally healthy community. We recognize that there has to be a comprehensive approach which incorporates drug-related laws and policies, as well as enforcement of these laws. We need evidence-based programs at community, school, workplace, and family levels, as well as targeted interventions at the individual level to effectively address drug demand reduction. We know too, Jamaica is one of the few Caribbean countries to operate most components of this multi-level framework, with evidence from national studies as far back as 1980. Being translated into practical solutions to address the realities we face. Certainly our aim has always been to activate this framework in order to delay the onset of drug use, reduce problematic use, and sustain public education on existing and emerging threats that exist in our context. These are critical components for achieving those aims, ladies and gentlemen. The demand reduction continuum starts with overall health promotion messages, advances to the implementation of various levels of prevention programs. Universal for all of the population, selective for those who are at-risk groups, and indicated to prevent the onset of problematic use among those who have started to use. And of course, we move on to screening and brief interventions and to specialized treatment, rehabilitation, relapse prevention. During 2019 and 2020, NCDA reached over 70,000 Jamaicans through drug awareness building activities. Of course, approximately 7,000 children and adolescents participated in structured school-based prevention programs. There were over 3,000 persons benefiting from community-based initiatives. On treatment side, we had over 800 clients in our counseling program, with additional 340 served through the drug treatment court system. We know that those numbers are reasonable and significant, but there's a lot more that needs to be done. The blueprint for a healthy community requires that all children be exposed to drug prevention throughout childhood into their adolescence. The approach to drug prevention, therefore, needs to be integrated into a broader youth development framework. Equally important is the need for sustained comprehensive public education, similar to past initiatives such as family planning. And we, of course, remember 2 is better than too many slogan, which has stuck with us to this very day. Formal incorporation of specialized drug treatment into the mental health plan and services is also required, with clear standards of care articulated and monitored through a structured framework. Additionally, expansion of additional addiction professionals would bolster the capacity to provide adequate quality care to those who need it most. Well, I think all of the previous speakers mentioned the COVID-19 pandemic and the COVID effect. And of course, this has resulted in significant changes and disruption to life as we know it. The National Council on Drug Abuse recognized very early that the pandemic required a comprehensive plan, which incorporated change in the way we deliver demand reduction services, engaging the public to raise awareness about possible impact of substance abuse, and of course, the adverse COVID outcomes, especially when you look at chronic smoking, vaping, and alcohol use, and seizing opportunities to create innovative and meaningful partnerships with those persons working on the ground. I outlined on Tuesday, ladies and gentlemen, we have seen a significant increase in calls to our helpline. When looked in the press, they mentioned that alcohol was a problem, but I need to correct them. What the data is actually showing is that our helpline, people have been contacting our helpline because of problematic ganja use, and over 70% of the callers have requested support for problematic ganja use. We know that alcohol could also be on a rise, but we are now doing the research to determine exactly to what level that does exist. And I must mention that this mirrors what we see in the treatment centers, as well as with 50% of the clients there accessing treatment for ganja use, followed by crack cocaine and use of alcohol. In addition, 90% of the adolescents in our counseling programs are being seen for ganja use. We are forced to do things differently, and instead of stopping our programs due to school closure and social distancing, there have been innovations that we've been undertaking to sustain and transform both prevention and treatment initiatives. National Council on Drug Abuse embarked on a digitization and animation of prevention program materials for delivery on local platforms. Edifocal and classroom one-on-one targeting both primary and secondary level students, because they normally get significant proportion of their schoolwork on these platforms. We've also successfully piloted a digital drug prevention game called Smokescreen in partnership with Yale University, which targets reviews skills building among 11 to 16-year-olds for tobacco use. There are also some opportunities we have seized in order to mitigate services to a digital world. We're unlikely to return to normal time anytime soon, and I think this is a reality we all have to face. So the sooner we make these changes, the better off our target populations will be. Building and strengthening partnerships for capacity building is also an opportunity we have seized. We have undertaken online training of the screening, brief intervention, and referral to treatment approach among over 400 guidance counselors, deans of discipline and health and family life education teachers, strengthen their response to student substance abuse. Similarly, 140 healthcare workers from Bellevue, as well as National Council on Drug Abuse staff, were trained to use a variety of modalities to respond to dually diagnosed patients, things like cognitive behavioral therapy, trauma-informed care, and so on. Changing social attitudes towards drugs and drug-using behaviors is a difficult undertaking, but not an impossible one. Many segments of society must become involved in effort. Message that drug use is unacceptable, unhealthy, and unnecessary must be communicated in a credible and consistent manner by all these stakeholders listed. Media and entertainment industries with appropriate guidance should carefully review their portrayals of drug use and its consequences and ensure accuracy of messages that are carried in these portrayals. The media and entertainment industry can become essential and credible partners in the anti-drug efforts of the nation if directed properly. They have a critical role to play in drug abuse prevention and building a mentally healthy community. We'll end by making an appeal for your participation in a current hemispheric online survey seeking to determine the relationship between COVID-19 restrictions and drug use in Latin American, Caribbean countries. Survey is led by our longtime partner, Organization of American States Inter-American Drug Abuse Commission. Kindly click the link uploaded by our conference organizers. Participate in the survey and share with your networks 18 years and older, as we are trying to get as many responses as possible before October 20, when the link expires. Today, Jamaica has had 526 responses. Please complete all questions and support us as we try to advance the effort of building a mentally healthy community and nation. Thank you very much.
Thank you very much, Mr. Tucker. So thanks to our panelists, Professor Abel, Professor Gibson, Professor Sams, Vaughan, and Mr. Tucker for their presentations. The first question that we have from our participants is actually aimed at Professor Abel. And we're being asked, at request of him, what does he think are the critical resources needed to build the mentally healthy community? And what barriers would he perceive would there be in actually achieving this healthy community?
That's a question for me.
Labeled to.
Okay, what are the critical resources?
Critical ones now.
Resources, well,
resources.
The resources you're going to need certainly would be, you need to have money. I mean, that's going to be critical. You're going to also need to have human resources. Mental health and mental health care involves high level of human input. You also will need, it's also important that we have the correct policy framework. And by this, I mean, even at the level, for example, the Ministry of Health, they have to ensure that, and I think Dr. Claudina mentioned that, Dr. Cayetano, that we need to ensure that a significant larger proportion of our mental health resources are directed towards mental health promotion, towards community initiatives directed to different levels of the community, the school, the workplace, faith-based organization, civil society organization. So we have to redirect our financial resources and redirect our priority, because what we do know in Jamaica, Caribbean, Latin America, the significant part of our mental health resources are tied up in manning hospitals, especially the mental hospital. And we also need to recognize that there are critical windows of opportunity for us to act, right? And one of them is the first 1,000 days. And I'm sure Prof. Sam Vaughan will elaborate on that, where it's a crucial area. And so we need to direct the appropriate resources during that period. And there are other windows like during adolescence and early adulthood that we need, which are critical points. And so you have Mr. Tucker speaks to the work of the National Council on Drug Abuse, and a lot of their efforts are actually directed towards young people, because therein lies another window of opportunity for us to act, to build mental health, to build resilience, and to build a healthier, a mentally healthier society.
The second part of the question speaks to barriers.
Barriers, and I'll be very quick. There are many barriers. I mean, barriers at the policy level, as I alluded to. Barriers, I mean, wider one is stigma, discrimination, which affects, I mean, how our resources are directed. And I think those are some of the, and financial is a major one, right? And if we think we had a financial crisis in the past, with the COVID pandemic, unfortunately, this is going to be worsened, you know, and these are some of the challenges that we're going to face moving ahead. But these are some of the major barriers, I think.
The next question is directed to Professor Sams Vaughan. She spoke about building that community within the day-to-day life through screening and early identification. This one I want to ask, given the adverse childhood experiences that many of our children face during this time, either directly or through television or through their other friends that have shared their experiences, how do families on a day-to-day basis help their children and their family to start to build that healthy community?
This is why there's such a great need for parenting support, because many parents do the right thing in Jamaica. Make sure your kid goes to school, make sure they're immunized. We don't have any of those problems in Jamaica, but many parents actually don't feel that they have what it takes to bring their children up to be emotionally resilient against the adverse circumstances. But there are some key things. One is that, you know, it's important to ensure that parents understand how important it is to tell children all the time how much you love and care for them. And the other thing that is important is, you know, that alone helps to build children's self-esteem. And the other thing that is important is to guide children who have had these experiences, the adverse childhood experiences, to support them through it, to seek help for them if they can't, if the behaviors are challenging or difficult, and make sure that if, you know, after seeking help, that they can actually provide some of the support back at home. Parents need a lot of support, and we're really not investing as much in parenting. It's a type of support that brings tremendous return, because, you know, if you live in a community and families see how well one family is doing, you know, parents can share their experiences. Getting parenting groups going in communities is another way to help and support parents. But really, we need to be investing more at the community level in parenting support.
Thanks very much, Professor. Professor Gibson, this question is directed to you. We do recognize that individuals who have now contracted the coronavirus do need help in coping. What suggestions can you give to those patients, as well as for the frontline workers or medical practitioners who are working in the field?
Okay, thank you. So I think a general concept that's applicable to the groups that you have mentioned would be to try to use resources that have worked for them in the past. In other words, each of us have had some difficulty, some stressful situation that we have had to face. And if there are resources that we have used, and I use the term resource very broadly, if there are resources that we have used in the past that have been helpful, then these are the kinds of resources that we should be trying to use again. In other words, there is no need to go out and reinvent the wheel. So if it is that you have gotten through a difficult situation in the past because you've been able to call upon somebody who is able to offer you support and guidance, or it is that you get involved in a particular activity that is relaxing and that takes your mind off the difficulties that you're facing, whatever it is that has worked for you in the past, try to do so again. One of the other things is something that I believe Professor Abel had mentioned in his presentation, which is try to tackle the situation from a position of empowerment. In other words, yes, the situation is difficult, it is challenging, but what can you do? What is within your power to make the situation the best that it can be? So this might involve making sure that you're adhering to protocols that are going to protect you from contracting the virus, for instance. Of course, if it is that you have tried resources and they're not working as well as they have before, you're still feeling distressed, then to try to seek some professional mental health support. Now, many persons are reluctant to do so because of the stigma associated with mental health challenges. But as I mentioned in the brief presentation that I had, I think what the COVID-19 crisis and pandemic has done is that it has made more of us recognize that mental health is something that is relevant for all of us, and that our mental health is challenged. All of us have this challenge to our mental health at this time, and I'm hoping that that makes it easier for persons to take that step forward and get the professional help if it is that that is what is required.
Thank you very much. Our other participant didn't name anyone that they wish to answer, so I'll leave it open to the floor. She's asked, what are the safeguards to community support, given that social distancing may have reduced interpersonal contact?
So, although social distancing has reduced the physical contact, thankfully there are technological means of having that kind of support in place now. So an example would be even in our operations at University Hospital. In reaching out to patients, recognize that it may be difficult for them to come into hospital, one. Two, they may be fearful because it's a hospital, there's a perception that it's, you're more exposed there. We have been using WhatsApp video conferences to get in touch with our patients and to offer them the support that they need. So I think, although there's a challenge with the conventional means, there are technological advances that allow us to offer that support anyway in this crisis.
And if I could also add to Professor Gibson, that a lot of mental health professionals are now providing online therapy consultation, and it's easier for us to do it. In fact, the entire medical establishment has gone online, but it certainly is easier for us to do it in mental health. And as the world has gone digitalized now, what we also realize that there are lots of mental health resources online. In fact, a patient walked into my office this week and said, look, I did my CBT therapy online, I did my workbook online, and I've purchased a mental health app, and I've gone through it and it has helped. So a lot of resources, and people are accessing these resources. Some free, some you have to pay for. Support groups in the community, whereas before we would rely to walking down to a particular location to join a support group. Support groups have just expanded online. So if you have a gambling problem or depression, you can join a support group in Australia or an international support group, right? So the world has shifted. COVID, as Prof. Gibson has said, has changed our world, and we now have access to wider resources that will certainly help to maintain a mentally healthy society and world.
I'm going to ask Prof. Sams to expand on that. How do we keep our little kiddies together? They no longer go to school to play. They no longer interact with each other on a face-to-face basis. What can parents do to help maintain friendships and in social interaction amongst our children?
Well, you know, it's lucky that we're living in the social media age, because now we can actually interact with persons without them being in the same space. So it's important that parents recognize that children need to have some time every day to interact with their peers. There are some children who don't have as much access, and they might have to borrow parents' cell phones, and so in order to get access, they may have to wait until the parents come home to get that kind of access. But it's really important that parents understand that children need to be interacting with other children, with their peers. Parents also should make sure that there is good family time. So, you know, there are downsides to the pandemic. There are some positives. Some of the positives include that, you know, we're rediscovering family. We're rediscovering ourselves in our own units, because, you know, previously sometimes some of us were overscheduled, everybody rushing out everywhere and nobody meeting together as a family unit. So it's important that parents reestablish that kind of family unit where people can talk to each other, help each other, and ensure that all the children have a voice. It's important that we not try to put the very young children aside because we think they can't express themselves. They can, and they will, and they do. And so we need to make sure that all our children have a voice in the family setting. And we also need to listen to our children when they say that they're hurting. When they tell us that they're hurting, we need to listen to them. If we can't help them ourselves, then it's important for us to seek that help elsewhere. And that help elsewhere, as many persons already know, that the National Parent Support Commission has hotlines for parents, and also the child guidance clinics are doing tele-counseling. So if you feel that your child needs some help, it's important that you know where you can get it, and it's important that our professionals know where to guide parents to get this help. So we start with what we can do in the home. We make sure that we use all the media for contacts outside, and we make sure that when we can't manage, we know where to get additional help.
Thank you very much, Prof. There's one comment from the participants, and that is, what about families who do not have access to the technological means? How do they stay socially connected?
Okay, I'll go first. So I think the point that Professor Sams Vaughan just made is a very important one. So the first thing is that they stay connected to each other. So I mean, the family as itself is a very important resource for providing much of the support that the individual would need. I think also, even if you don't have access to you know, the more high-tech kinds of technologies, most persons have access to basic communication technologies, television, radio, etc. And I think that helps even persons, let us say persons who need to be at home, for example, older persons, does help them to connect to the wider world. I don't know if anybody else has any additional thoughts.
We're being reminded that though we're physically distanced, we must remain socially connected. And for those individuals who feel as though there is no way that they can find or identify someone to which they can connect to, and they do need assistance, there's the Mental Health and Suicide Prevention Helpline at 888-639-5433. Mr. Michael Tucker, final question. Have you had an increase in concerns about the use of drugs during this time of COVID compared to previous years?
Yes, there has been an expression of concern. We recognize, and has been said by everybody else, that people's lives have been turned upside down. Normal scheduling has been disrupted. In fact, many people have lost jobs and their income has been significantly affected. We can't just think about those people who own small and medium-sized businesses and the fact that you have a curfew that starts at 8. So therefore, in terms of opening hours, etc., especially people who sell food and beverages, how they've been affected. So yes, we recognize that there may be temptation to turn to alcohol and other drugs because of the stress, because some people are getting depressed, because some people can't really cope with the situation. Because as the psychiatrist will tell you better than I, when people are not in control, they feel out of control, they feel hopeless, they feel down and out, depression sets in, they're stressed, there are other issues that set in, and drugs may be what they turn to. So we have had significant amount of calls to helpline we've established. If you have noticed on primetime television, etc., we've been reaching out to people to say, if any family member has been affected by smoking or drinking, call us, we are here to help. And we've been doing a lot of work where that is concerned. As has been mentioned by some of the other speakers, we've had to do a lot of it online, and we've honed up our telephone counseling skills, but there are a lot of people out there hurting, a lot of people that need help, a lot of people that are in crisis.
Okay, final question for the evening. Someone has asked, what measures are in place to protect the most vulnerable during this time? Since isolation, despite not meant for it to be, but in terms of distancing, there has been some isolation. There's also been isolation where family members who work, example for caregiving situations, would stay away from other elderly family members. So what measures have been put in place to protect the most vulnerable during this time that promotes isolation? We're talking specifically now along to the elderly and those with mental illnesses.
I probably try to yes, I'll try to attempt to answer that question, because the measures, there are a number of measures that have been rolled out at different levels, at the national level through the Ministry of Health and Wellness. And this week, I think the minister addressed the community-based intervention. They have a helpline in place. I notice also Rise Life Management also has a helpline. National Council has a helpline, and these helplines are open lines, so people with mental health problems, substance abuse problem can call these lines to seek help. As I indicated, a lot of mental health professionals have gone online and they're accessible. I realize that there's a high level of activity in social media, providing information and increasing access to different levels of mental health care. Must also tell you that at the community level, critical community organizing, at different levels of the community, the schools, through the Ministry of Education, have also rolled out mental health initiative to support teachers, guidance counselors, students, parents. The Parents Teachers Association, I think they're also doing there are things that they have implemented. Faith-based organizations across the countries are doing a lot of activities, you know, at the community level. Community-based organizations are involved. In fact, I'll tell you this. In all my life, in fact, my admin assistant said to me this week, she can't believe how many lectures that I actually do on a weekly basis as I interact with, train, with so many organizations. And this, in fact, takes us back to the level of the university, because, you know, the University of the West Indies actually led out very early, even before we identified our first case in Jamaica, by doing a pandemic conference. And we've had subsequent conferences organized by persons like Professor Vaughan, Professor Eldemeyer, working with the elderly. So the university also recognizes it's the critical role that it plays in nation building, and also plays in terms of delivering services, and also is doing a fantastic work, I must say, on the ground all over Jamaica.
Thank you very much, Prof, for the presentations. Wonderful to have heard from all. Just reminding all that NCDA helpline is 888-564-HELP for drug abuse counseling, and the suicide prevention helpline is 888-639-5433. This brings us to the end of day 5 of our Mental Health Conference 2020, Investing in Mental Health. The time for action is now. It's never too late to do something. Today especially is significant as it is World Mental Health Day, October 10th. We'd like to thank all those who were present today, or those who brought us greetings very early, Dr. Earl Wright and Ms. Ho. We'd like to thank our main speaker, Dr. Claudina Cayetano, who's a regional advisor on mental health for the Pan American Health Organization. And we would like to thank all our panelists, Professor Wendel Abel, Professor Roger Gibson, Professor Vaughan, and Mr. Michael Tucker for spending the time with us. And of course, this could not be possible without all our participants being here with us. Thank you to everyone, and we go out there with the charge to promote and ensure mental health for our community. Good night, everybody. Whew.